Sarah, are you here? Hi,
Hi, Linda.
how you doing?
Good. How about yourself?
Pretty good, pretty good. It's a great day down here. No snow, no bad. So, if anyone is there anything we need to discuss before we ask Sarah to present the findings of her survey?
Can I just ask, I don't think I have the final version of the survey, or has that been sent around yet, or no?
No, that's my fault. I'm terribly sorry, Mike. I'll send it to Beverly after this meeting, if that works for you.
Okay.
I have it. I just haven't sent it. I've been out of town, and the person who does a great job on formatting and our publications has been out of town. So, but I can give it to you.
Okay. And just for the information of the folks who are viewing this meeting, we should have all seen the actual the raw data and analysis, and I think the final version was a question of formatting and coming up with the introductory paragraph and things like that. So the members,
so we have a draft. We have a draft.
Yeah, the task force have seen the meat of it, and and I presume once you send it, we'll make it public so that others can see it as well. I'm thinking, right?
Okay, thank you. Mm-hmm.
All right, Sarah, please proceed.
Okay, so I'm going to share my screen. So I'm going to kind of leave, and I mean, just visually speaking, and then you'll see my PowerPoint. Okay, do you see everything okay, and you can hear me okay?
No. Yep.
Here we go. Hang on one sec.
There you
go. Okay, we're good?
Great.
Yep.
Okay. So I want to thank you for having me here today, and I will be presenting on the Connecticut Valley Hospital and Whiting Forensic Hospital Workplace Survey. I'd like to start off with some acknowledgments. I'd like to thank the respondents for providing valuable information for the survey, and we'd also like to thank the CVH Whiting Task Force for the opportunity to work on the report and for reviewing early drafts of the survey. I need to read a disclaimer. This report was supported by funding from the Connecticut General Assembly. Its contents are solely the responsibility of the authors and do not necessarily represent the official views of the Connecticut General Assembly, the CVH Whiting Task Force, or any Connecticut state agency. Just as for a brief background, which I'm sure you're all very well versed in 2018, Connecticut's General Assembly enacted and the governor signed PA 1886. Among other things, the statute directed the task force to evaluate the need to conduct a confidential survey regarding the employee work environment at Connecticut Valley Hospital and Whiting Forensic Hospital, including but not limited to worker morale, management, and any incidences of bullying, intimidation, or retribution. The task force contracted with the Center for Population Health to develop and administer the survey and analyze the results. Okay, going to move on to some methods. So we developed the survey by reviewing the literature. We researched existing surveys for items relevant to the 3 domains. We worked closely with the task force to develop the survey. We pilot tested the survey with a task force and 10 individuals and formatted the survey for online administration using SurveyMonkey. The task force sent out an introductory email on March 15th. Later on that day, we sent the survey link to the participants. Subsequently, we sent out 3 reminders and closed the survey on March 31st. The research design was non-experimental, and we used quantitative and qualitative research methods. The target population was 1,518 employees. We had 417 individuals participated in the survey for a response rate of 27%. 146 responded to the open-ended question, which was a response rate of 10% of the overall sample, but over a third of the survey participants. Now moving on to the description of the sample. There was 60% female. About 63% of the sample was 45 years of age and over. 40% were non-Hispanic white. 26% were mental health assistants and forensic treatment specialists. That was the most frequently cited professional role. Over half were CVH, worked at CVH in some capacity. 60% worked the day shift. 40% said they worked overtime. Of that 40%, let's see, of that 40%, 49, almost half, reported their overtime was completely or mostly voluntary. 50% spent over 60% or more of their typical week in direct patient care. And now we're going to move on to results regarding worker morale. Just as a little background, the intro to the worker morale question stated, for each question below, please select the option that most closely represents your response. Please consider those activities or experiences that have occurred in the past 6 months while working at CVH or Whiting. The response options were strongly agree, agree, neither agree nor disagree, disagree, or strongly disagree. Strongly agree and agree were combined, as were disagree and strongly disagree. Based on the quantitative results, it appears that respondents get intrinsic satisfaction from their job and that they feel most of their colleagues are easy to get along with. Respondents report knowing what is expected of them on the job and knowing how their work relates to the organizational goals. Slightly more than half of the respondents reported having enough information to do their job well. Less than half of the respondents report having the opportunity to improve their skills. Less than a third report feeling encouraged to come up with new and better ways of doing things. Over half of the respondents report that their workload is reasonable. Less than half report that the physical conditions allow them to perform their job well. Around a third report they have sufficient resources to get the job done. When asked if they would recommend their organization as a good place to work, the responses evenly break down into 3 categories: agree, neutral, and disagree. We ran some analysis, some additional analysis to investigate whether certain employee demographics and job characteristics affected respondents' impressions of the job morale. So this is what we looked at. So non-Hispanic white, yes or no, male, female. We broke age down into 2 large categories. The work location was CVH or Whiting, whether they worked overtime or no overtime. And if they worked overtime, whether the overtime was mandatory or voluntary. If they worked the day shift, if their patient care was 60% or less or over 60% of their typical work week. And we combined mental health assistants and forensic treatment specialists versus all other professions. So what we found with this is worker morale was significantly more negative for respondents who reported overtime, worked mandatory overtime, worked over 60% in direct patient care, and had a job classification of mental health assistant or forensic treatment specialist. The very last question of the survey was an open-ended text field that stated, please provide any additional information about your experience working at CVH or WFH. 146 participants, that's about 35% of the individuals who participated in this survey, provided a comment. The comments averaged 142 words and ranged from 2 to 1,003 words. Most of the positive there were 7 individuals who provided only a positive comment. I can read you some of them. The staff likes to offer help and work hard to help the people we serve. Most of the employees get along well. We work, laugh often, and support each other when dealing with hard cases. Another quote, I am thankful to have a job. I have no complaints about working in X. I love my job. You will never hear me say bad things about my place of employment. Another quote, I love it. It is a wonderful privilege to be working at X. There were about a third of the participants provided positive comments, but with a qualifier. For example, when adequately staffed, adequately managed, and adequately trained, and adequately resourced, X and its employees are the best. There are others, but I think that kind of represents the gist of it. And now overall worker morale comments, about a third of the participants mentioned something. For example, everyone is miserable from the top down. Morale does not exist. Another quote, the morale in this building is at an all-time low. People show up because they have to, and it shows. There are negative patient comments associated with the morale of the building. Another quote, this place cares nothing about staff morale or well-being, but instead fires on the spot or put staff through stress to maintain employment by staff walking on eggshells. Okay, we're going to move on to results related to bullying. The preface to the bullying questions stated, for each statement below, please select the option that most closely represents your response. Please consider behaviors or experiences that have occurred in the past 6 months while working at CVH or WFH, and that involve managers, supervisors, co-workers, or supervisees. Please do not include behaviors or experiences that involve patients or patient family members. Response options were never, occasionally, monthly, weekly, daily, or NA. As we look at these bullying behaviors, you'll see that we also said nonviolent or uncivil included that. That was primarily based on the literature. And just as a little background, the definition of incivility and bullying, where they differ, is that they're often the same behaviors, but the differences are in intensity, duration, frequency, and intent. So if you're looking at this, the orange or the yes part of the bar indicates if someone said, if somebody selected anything that was occasionally, monthly, weekly, or daily. So you can see all of these on all the items on this slide, we had 50% or more. So more than half of the respondents mentioned that they had experienced one of these items. I'm not going to read all of these items because there's so many of them, but you can see that, you know, although these were selected by less than half of the respondents, it's still something to consider. In response to the statement, I have witnessed coworkers being bullied by managers, supervisors, peers, or supervisees. So a third said never, about a third said occasionally, and a quarter said often. When analyzing the data by demographics and job characteristics, we see a significant difference in site of work, age of employee, and race of employee. Um, 8% reported that they had experienced violence or physical abuse. 10% experienced a threat of violence or physical abuse. And although these numbers may be small, it's still, I mean, to go to work and experience violence or physical abuse or threat of violence or threat of violence or physical abuse is something to be aware of.
Can I just ask, is this just among employees, or would this include violence between them and a patient?
So that's a very good question. So that's why we phrased the introduction to this set of questions related to bullying to only include managers, supervisors, coworkers, or supervisees. And we ask them, please do not include behaviors or experiences that involve patients or patient family members. But I can't guarantee that someone didn't, when they were responding to this, because a violent or physical abuse, an experience of that could be so salient in their mind that it could be something that they would remember and perhaps report.
Understood.
And then the question too is, was it a staff member to a patient or a staff member to another staff member?
Yeah, that we can't determine by this question.
Okay.
Right, but good questions. Have you experienced any negative behaviors from people you work with? So nearly 3/4 said yes to that. Now we asked individuals, when asked the source of these negative behaviors, respondents reported, so 87 reported, stated coworkers either occasionally or often were the source of a negative behavior. 65% stated managers were either occasionally or often were the source of the negative behavior. 59% stated supervisors, and 35 stated supervisees. So I don't know if that somewhat answers your question. This is negative behaviors, but not necessarily the violence or threat of violence or abuse.
I mean, I think the violence question that Paul asked is actually very important, because I mean, my daughter's just a nurse in a regular hospital, but also has a psych floor. But I would say once a week, she's hit, punched, slapped by a patient. So I think, you know, who the perpetrator was, unfortunately, and it's not nothing we can do now, but if it's an alarmingly high number, if it's not patients against the respondent, if they're really worried about their well-being by their peers or supervisors, that's a very disturbing.
And so, John, I raise that because advocates, we tend to hear anecdotally a lot that the staff provoke people to go off, so then that there's overtime available. You know, so I mean, that's why I think that's really an important question, that I kind of wish we could have gotten to the bottom of that, but.
A little less than a third of the respondents mentioned bullying in their open-ended comment. For example, it is impossible to report bullying, discrimination, etc. People do retaliate. They are just very careful about how they do it, but does happen. I have witnessed on many, many occasions of bullying, discrimination, many other inappropriate behaviors by staff. If you are not in the clique, it falls on deaf ears. If management doesn't like you, but your work is excellent, they form opinions from other people's opinions, and then they begin to harass you in subtle ways. There are others, the staff who are aggressive and yell at other staff the managers will ultimately side with because management is afraid of these staff. Management continues to bully staff, maintain a hostile work environment, retaliate against staff for voicing concerns, and generally does not respect staff or the work we do. Moving on to management questions. I'd like to note that management is the broadest construct of the three that we analyzed. And so there are several sub-themes under management. So this section is fairly lengthy. The preference to the questions related to management stated for each statement below, please select the option that most closely represents your response. Please consider behaviors or experiences that have occurred in the past 6 months while working at CVH or WFH. Response options here were strongly agree, agree, neither agree nor disagree, disagree, strongly agree. So in terms of a sense of having a team or team units, nearly 3/4 of the respondents stated that they enjoyed working in the teams that they were involved with, and nearly 2/3 stated that most of their colleagues were easy to get along with. There was also a fair amount of individuals who reported some conflict or difficulty working with others. Based on the analysis of the demographic and work characteristics, women had a significantly more negative view of team cohesion. Staff shortages appear to be an issue, with nearly 80% of respondents endorsing this item, and a fair amount of respondents reporting it was difficult to take time off. Adequacy of staffing are significantly more likely to be a concern for individuals who work overtime, work mandatory overtime, work in direct patient care over 60% of their time, and work at Whiting. Attitudes towards management. The majority of respondents feel their performance appraisals are fair. Less than 1/4 of respondents have confidence in management, feel there's excessive monitoring of their work, feels management values constructive criticism. Few respondents feel management consults staff before making decisions that affect staff. Attitudes towards management is significantly more negative for people in the non-management category who work overtime, who work mandatory overtime, work in patient care more than 60% of their time, and work as a mental health assistant or forensic treatment specialist. In terms of handling of errors or mistakes, majority of respondents feel they would know how to report unsafe clinical practices, feel management encourages staff to report errors or mistakes, feel secure in raising concerns about unsafe clinical practices. Around 1/3 to 1/4 respondents feel management makes sure errors or mistakes do not happen again. Feel safe to disclose a suspected violation, confident that management would address a concern, feel safe to bring up issues, or given helpful feedback about changes made in response to a reported error or mistake, feel management treats staff fairly who are involved in an error or mistake. Attitudes about management handling of errors or mistake are significantly more negative for respondents who work at Whiting, have mandatory overtime, have direct patient care over 60% of the time, work as a mental health assistant, or non-managers. Discrimination at work. 19% felt they had experienced racial or been discriminated against based on race or ethnicity, 12 based on gender, 7 based on age. Discrimination by race is significantly higher for those who are non-white. Discrimination by gender is significantly higher for those at whiting. The vast majority of respondents respect their direct supervisor and feel their direct supervisor treats them with respect. Half of the respondents respect management. Around a third feel management treats employees with respect. Again, doing some comparison analysis, you can see in terms of respect, mental health assistants are significantly lower, having working 60% of time in direct patient care is lower, non-day shift is lower, and non-management is lower. And when analyzing the data by demographics and job characteristics, respect for management was significantly lower for mental health assistants, mandatory overtime, and whites. So 71% of respondents mentioned some aspect of managerial practices in the open-ended comments. They had to do with decision-making, feeling comfortable with communication. There was a lot of discussion of working in fear of being punished or fired. For example, the only cohesion among management that I see is the implementation of severe punishment and intimidation tactics. We are in constant fear of losing our jobs. There's safety concerns. Individuals reported feeling unsafe or that administration didn't protect them. They've been assaulted by coworkers and severely injured by a patient. Lots of discussion of overtime issues. Working, since this pandemic, every day I work is 16 hours. Either I volunteer for overtime or I will be mandated. Either way, I'm still working 16 hours. They do not care if you're working short staff or we have to be mandated every day. They're doing nothing to take care of the staff shortage. Issues around patient care. This shift allows staff members to engage in therapeutic activities and engage the clients in more treatment plan related activities. Clients that build the tools to ready themselves to be integrated into the community is enhanced and length of stay is shortened. The ability to reestablish therapy and the client's ability to attain this highest level of functioning should be our highest priority. I used to think X was the greatest job. Now, due to horrible management, the job we are supposed to be doing, making sure patients are safely receiving treatment, is a far cry from what we do. Now, we just house patients and try to avoid run-ins with management. It's also discussion of lack of opportunity for a professional advancement and professional development, and some comments on discrimination. And there are quotes in the body of the report and in an appendix, so you can get those there if you would like. There are some limitations to the analysis, and that is it was just a snapshot of time, and there were some unique events in the past year. The most dominating one, of course, is the COVID-19 restrictions, etc. There was a limited response rate of 27%. Although this is on the low side, it is in the range of surveys with similar samples using online methods to survey healthcare professionals, which have had response rates ranging from 20 to 38%. And some of these studies offered respondents incentives for participating in the survey, which has been shown to increase response rates. Gender and race distributions were compared between survey respondents and the CVH whiting workforce as a whole. And these were the only demographic characteristics for which DEMIS provided workforce data. The comparison revealed that no demographic groups were unrepresented on the survey, although there was some concern with underrepresentation of males and Blacks. So let's kind of talk about some of the areas of strength. I would say, well, let's back up a sec. So the concepts of worker morale, bullying, and management are interrelated. So if you were trying to develop your recommendations, it's hard to have one without the other. So, I wouldn't say, oh, let's make sure we, because I know the state of Connecticut has, like, say, a, bullying policy, but that in and of itself can't correct things if there's, bad worker morale or some concerns over management. So you have to kind of work on all of these levels if you're going to make any progress with any one of them. The qualitative responses were more emphatic, and I would say probably more negative than the quantitative results. Over 1/3 of the respondents provided a comment. And as I mentioned, it ranged from 2 to 1,003 words. And I have never seen that many responses and that much detail in the responses and the length of the responses as I have in this survey. So I think folks, they were very emphatic, and they had definite opinions about things. Which just leads me to believe that that there's a fair amount of stress going on in the environment. And this was the last question. I mean, it was after even the demographics and the background characteristic questions. Okay, so in terms of strength, I do think that the respondents get intrinsic satisfaction from their job. I think they care about the job and they care about patients. There's evidence to suggest that they like their teams or their coworkers, at least some of them, or find them easy to get along with. They know what is expected of them. They feel the direct supervisors are respectful, and they respect their direct supervisors. I would say areas in need of improvement, you could kind of have it, and I'm open to what you folks have to say and how you interpret some of this, but it seems like the whole notion of like being heard, being able to come up with new and better ways of doing things, being involved in decision making, or being asked what's the best when decisions are being made. Handling of errors, they seem to know how to report it, and that management encourages reporting it, but they feel that there's limited action to prevent errors from happening again. They don't get feedback about the changes that are made, and they don't feel that staff are treated well. In terms of resources, that was a little low, feeling that that they didn't really have the resources they needed. I think staff shortage, overtime, having mandated overtime, and also to consider that voluntary overtime is not always really voluntary. Sometimes they are volunteering so that they don't get mandated into a shift that just isn't going to work for them. Respect seems to be an issue, especially respect around managers to staff. There's a fair amount of bullying and incivility going on. And although the experience of violence or physical abuse, as we kind of discussed, may be low, that's something that you want to aspire to have really low or or zero, and I don't know in the environment that, in that particular environment, if that's realistic, but it is something to aspire to. And that discrimination does exist. Or reports of, or perceptions of discrimination. Where people, if you're going to look at job characteristics and demographic characteristics, who's, I don't know what the right word would be, who's struggling the most, who's reporting, more negative perceptions, it would be folks who work overtime, work mandatory overtime, and there's a pattern here, work in patient care over 60% of the time, or non-managers and mental health assistants, forensic treatment specialists.
Sarah, can I interrupt you for a minute? I'm sorry. I guess I should ask the chairs if I can interrupt Sarah, but.
Yeah, I'm done. Please.
Yeah, no, I don't want you to be done. I just want to ask a question. So obviously we're not doing multiple regression analysis here, but it's really a question, I think, for Lori. It seems from that series of questions about this stuff that, if I had to say, it looks like it's the same group that are MHAs. First of all, I used to run a hospital, right? Nobody ever mandates overtime for anything other than direct patient care, right? It's very unusual to mandate it otherwise, right? So it sounds like those are all, or more frequently, the folks that are being asked to stay overtime or told to stay overtime, mandated to stay overtime, are MHAs. It's non-management, more whiting. And before I conclude that or infer that, I want to make sure or ask Lori, is that her sense of that?
Yeah, yes, John, that's accurate. That these groups that Sarah's describing, they're all essentially they're all the same thing. The MHAs, the FTSs are the ones that work the overtime, they work the mandates. They have the most patient care, they're non-managers, it's all the same folks.
Yeah. Any other questions, or if you wanted to discuss things among yourselves, that's.
I have a question, and maybe it's unfair to ask this, but you hinted at it when you were characterizing some of the commentary, the narratives from some of the employees there. But I'm guessing, Sarah, that you've done this type of a workplace survey frequently in the past. And so my question is, and again, the caveat, maybe it's unfair to even ask this, but is there anything in here that sort of stands out from what you've experienced in other similar surveys?
Yeah, I would want to, I'd want to ponder that a little bit more, if you don't mind. But I think what did stand out and what I kind of mentioned is like just I've never seen that amount of text from any group. Usually we get at the end of a survey in an open-ended thing, there's a lot of thanks or, either, or this place, I wouldn't recommend somebody working here, or, or this place is great, or, but, whatever, or, can't wait for retirement. I mean, you get something that's kind of brief and not really particularly meaty. People over 1,000 words that somebody provided. They have either they have strong opinions or they're very verbose. It's a very verbose group, or they're really struggling. There's something, there's something going on.
And we're gonna be able to see the entirety of these narratives once you make it available. Is that the case?
I did a brief summary in the back of the. I didn't do everything. It's a lot, and I selected ones that I felt were representative of it. They're in the appendix.
And so the 1,000-word submission was not an outlier. There was a bunch that were relatively long. Is that what you're saying?
Yeah, well, the average was what, 142 words, which isn't particularly long, but
Got it.
It's a paragraph, not a sentence.
correct.
I guess my question, Sarah, is so it seems like one of your findings is that people aren't feeling heard, and so would these long responses be more indicative of how how much they want to be heard? Like,
I think you could, yeah, you could interpret it as such. Yeah.
This was a snapshot of how people felt for I think a 2-week period in March.
It was, we requested a 6-month look back, but the survey was open for approximately 2 weeks.
Okay. 2 months later, a unit in Whiting was closed and staff and patients were redistributed throughout Whiting. And the reason for the shutdown was allegedly because of staff shortages and that it was dangerous on the unit. So do you have any way of knowing, and I guess I'm sure you don't, but I'm really curious as to if you had done the snapshot on May 19th or May 20th, or after that unit was shut down because of staff shortages, if you think that you would have gotten a different response.
Yeah, it would be strictly conjecture on my part,
Right.
and so I can't respond.
Does that skew the results in any way, knowing that there was such a major change in the functioning of Whiting 2 months after the survey results?
I mean, I can only base the survey results on the time period of the time period of the administration of it. So,
I mean, do you think people, and I understand this is conjecture, and I don't know if, you probably can't make this, this guess, but if people would say, oh, they're finally listening to me. I've been telling them, or I've been trying to tell them, or I wanted to tell them, now they're listening to me. There's no way of figuring that out, I assume.
correct.
Yeah.
Sarah, this is Linda, and I was just wanted to take Paul's point a little farther. You said you've never seen that kind of a fill in the blank at the end of a study like this. And I'm wondering, 2 thoughts came to mind. One, maybe they really think this is going to do something, and that's why they took the time to actually put forth their thoughts on paper. But I also agree with Paul's notion that maybe they don't think anybody is really listening to them. And maybe that is one of the basic issues that we have with staff morale. You have any thoughts on that?
I think I think that's a possibility. Also, I just want to say that based on my reading of the statute, our job was really to kind of develop and administer a survey and then analyze the results. And the task force role would be to come up with recommendations. So I don't feel like I'm an expert in coming up with these recommendations. So I think that, you should take whatever I say with a grain or two of salt. I think you folks are the experts, and to come up with the recommendations.
I'm not sure it's, to be fair, you know, having done surveys for my employees for, seems like forever. I'm not sure it's our job actually to come up with how these issues are to be addressed. I think our job is to, and I think you've done a great job in articulating and highlighting the 4 or 5, you know, key areas, whether it's teamwork or bullying or morale or mandatory overtime. You know, I think we have plenty of material to work with, and I think our job is to identify those areas for management and the legislator to take back to management so that they can make sure they address it, right? Or at least ask management, how do you plan to address these things? I mean, am I wrong for my task force, you know, chairs, or is our job specifically say, you know, stop doing mandatory overtime and you know, stop bullying? Is that really what we're supposed to do?
I would just say that we have, as she was debriefing on this study, a lot of the information that we've already gathered and some of the interviews that we had with staff, you know, it just seemed to actually confirm in my mind some of the things that we have been discussing and identifying as problem areas. I'm not sure everybody else agrees with that, but that's my take.
I just asked that we stop the screen share so we can all see.
Oh,
it.
yep. Here, let me, hang on one second.
I think the survey results put some meat on the bones of what we kind of thought, is my sense. I think it gave us a little more detail, a little more granular information that I think will be very helpful. And Sarah, thank you, by the way, for putting together and conducting the survey.
My pleasure.
I just have to say, Sarah, when you said I have never seen, that kind of tipped my attention there. You've never seen this? People, you know, actually taking the time at the end of the survey to articulate in some length what was on their minds and what it probably, the survey itself was provocative for some of them, but then to come forward. And I would very much like to see what some of those statements were, because we have had the opportunity to interview a small segment, but some of the thoughts that we have about the situation with staff maybe could be highlighted by those comments as well.
Mhm.
Is there any other, Laurie, sorry.
Yeah, sorry. I just had a quick question for Sarah, and then I guess a general statement. So Sarah, when you analyzed all of the summary scores according to those different demographic and job characteristic groups, you did that for all of those. So would it be fair to say that if they're, because I was curious about like any differences between CVH and Whiting, you know, but it looks like there was only a couple things where that popped up as differences. Those were analyzed separately for CVH and Whiting, all of those things?
Yeah, the good question.
Okay.
Thank you. You're right. So all of the items were, scales were analyzed again by all those comparisons, including CVH Whiting. I just reported just for simplicity. I just highlighted the ones where there were significant differences.
Right. And are there, I don't know if you'll include this in the final report or not, but are there effect sizes that you can report on them? Because I know some of them, even though they're significant, they're very small differences between the groups, whereas others were a little bit larger. But
yeah, I don't think we included that. In the report we have, we have all of it, and then we have appendices to show it. I don't believe we did effect size, just because I think the sample was probably maybe too small to really come up with that. But
okay.
But I could double check on that.
Yeah. And I don't know, I guess I have an additional question. If there's, like, in your review of the literature, I mean, like, you know, this is apples and oranges in some ways because it's not the same, you know, survey or same instruments and whatnot, but just in your review of the literature, or in these kinds of settings, does this seem consistent? Does it seem worse than what other studies have reported in terms of like whether healthcare workers feel similar kinds of ways about, with regard to morale and bullying and management, things like that?
Right. I would want to revisit the literature before I made any kind of emphatic statement, but we know nursing, there's a fair amount of physical demands and potential of abuse in the field of nursing, and and discrimination in towards certain segments of the population within healthcare.
Yeah.
So some of this, and I didn't include this in the presentation again, because, we don't want to have death by PowerPoint, but in the report, we did compare management to non-management on a lot of these items. And there were some significant differences there. But again, that's not surprising, that if you're a manager, you kind of view you're doing, or whomever, you don't even have to, I don't want to pick on management, but, whoever is in the role of providing leadership or whatever, they do feel they do a better job than the people who report to them. So some findings, although they may not be, ideal, they're not particularly surprising, kind of to your point. And the whole notion of, in the literature, you do see often that, like, I like my direct supervisor. I'm not crazy about management. You see that a lot in organizational, and that could just be, like, you interact with your direct supervisor, you have more of a personal relationship, them, you see them as a real person. Management is just somebody way up here that,
entity.
Yeah, they're distant and they're just making my life miserable.
Yeah.
Type,
This is probably another extrapolation that you can't make, but given especially your surprise at the number of and the vehemence of the written comments and the level of distrust and unhappiness, etc., how does that relate to safety and potential safety concerns for the patients?
I think you might be asking two different questions. Are you help me understand your question. So are you asking, is the amount of text, and also I just, because I made that statement and everyone else is kind of, bringing it up, I mean, keep it within, I just wouldn't want to, just don't take that and turn it into something more than it is. Was it a surprise? Yes. Is that the end all and be all of this entire report? I certainly hope not. So I hear two questions from you. So one is the length, and that I was surprised at the length and the kind of content of the written comments. And two, I hear an issue about patient safety. And
well, my question is if people are that unhappy and distrustful of management, generally not happy, can that affect patient care and or patient safety? For if people were so dissatisfied with their jobs and
right. There were, because I want to stay very close to the data, and I will only make comments on that, and not to be rude to your line of inquiry, Nancy. It's just, I'm just wearing my researcher hat. So what I would say is that there were some quotes related to patient safety, and those are in the report. But I mean, it would be up to it would be hard to say that it doesn't affect patient safety, but that's kind of up to you as a task force to interpret. Unless I could find a specific and sizable amount of individuals who pointed directly to that, I wouldn't want to make a statement on that.
I would comment on this regarding safety. I mean,
Excuse me,
We
John,
could-
for some reason, you're muffled when I listen to you.
oh, I'm sorry. Can you hear me better now?
Yeah, it's still muffled, but that's okay. I don't know if it's your ears or
Let me unplug this and is that any better?
a little.
Sorry.
No, that's okay.
I think to Nancy's question, I mean, as a general rule, certainly I think if you had everybody was a disgruntled employee that felt the management stunk and there was no teamwork, that invariably would affect safety. I'm not sure that's what the results show, to be honest with you. But that being said, they actually kind of dealt a little bit specifically to this question when they talked about, identifying safety kind of issues and bringing them forward. But then remember, it didn't sound like there was a good feedback loop to the employee. And I know from my own experience that, it's only part of the issue to get people to report things. The better thing is to then act on it and then give the feedback to the person who reported, because then they get the feeling they listened to me and look, they did something to prevent this from happening again. So I think in there is some of that more directly, but I again, I'm not sure we could generalize to based on the results that I've seen.
Right. And John, I think that's I'm sorry, Paul. John, I think that's a very good point and probably a good path to take if you wanted to make any statement about patient safety rather than using the qualitative, rather than trying to create something based solely on the qualitative. All right, Paul, did you have a question?
Yeah, because I think that, the thing that kind of sticks out for me is the prevalence of bullying that seems to be going on there, because that really seems to go to a toxic environment. And I can see it's like I kind of see this where, management's feeling bullied. So then, the next level's feeling bullied, the next level's feeling bullied, the next level's feeling bullied, and that's going to trickle to the patients. But I guess my question is how does this compare to like an average workplace, the level of bullying that we're seeing?
Again, I would want to double check with the literature. And then you can ask yourself, and this is just something to think about. You can ask yourself, what do we want for my organization? What do we want for, or for your organization? Do we want to just be average in our bullying level and find that acceptable? Or do we want something that is highly functional?
And so, I mean, I guess we would all answer that we would want a zero bullying workplace. At least I hope we would. But I'm just wondering, like to me, it just seems like a very high level of toxicity going on in Whiting. And to the point of, I don't know. Is it like so high that it's that we need to look at drastic measures, or is it something that we can, turn around fairly quickly? I guess that's the thing, because to me, I mean, this has always been about culture. This has always been about the culture that's going on in Whiting. It comes down to, this. They watch the same TV station every day. And so you start to, get that circular logic and stuff like that. And I think where there's a place where there's bullying that prevalent, that bullying a patient just seems natural. And so I'm wondering if it's at that level where it's just too natural, the level of bullying that's going on there, where it's just too much the norm.
Just one comment. I would just say we can't say that it's bullying a patient. You mentioned bullying a patient, and based on the results, we couldn't really say that.
Right. And so I'm taking it to the step where I just don't think that people just bully one,
Yeah,
where,
yeah, yeah,
you
yeah.
know, that it stops. That, you know, to me, there's ripple effects that will go through and, you know, touch people even outside of Whiting. You know,
Well,
so
and to interject too, like, I mean, keep saying Whiting, but like this was one area where there was actually more at CVH than at Whiting. So I don't think it's just specific to the one in terms of the bullying, the extent of the bullying that's going on.
yeah, no,
And that's why I was asking that question too, Sarah, about like how it compares to other places, because it does help to at least put in a context of, you know, is this something that's sort of typically present in a healthcare setting or in this kind of setting where there is a lot of direct care and whatnot, or is this, you know, kind of over the top? And then it would help to inform what we do.
right. And
Maybe I can help on this one, because at least in the last two hospitals I've worked at, Stanford with 300 bed hospital with 3.5.
John, we really can't hear you.
Yep. Sorry. Let me try to speak closer to the. Is it better?
Yes.
All right. Sorry. God, I feel like I'm shouting. I got to get this mic fixed here.
I know the
in
feeling.
Two hospitals that I've worked, we've surveyed all of our employees every 2 years. So one hospital had 5,000 employees, the other one had 3,500. I like Paul, and I'm going to agree with Paul on almost everything. I was struck by the degree of bullying, and I think it wasn't just bullying; it was the milieu that the folks are working in. Right there, and I wrote down morale was an all-time low. Again, I'm kicking your words back at you, Sarah. They felt like they're working on eggshells. They're ignored, treated rudely, disrespectfully. This is not what. Like I said, and don't misunderstand. I've seen bad survey results of my employees, and we've taken actions, but they don't look like this. Yeah, sometimes they don't feel like it's a total teamwork, or they might have specific issues about a specific manager, and it helps us kind of focus on where the problems are. But I think this is not a healthcare issue. This is really a Whiting and CVH issue. And I was also struck by the fact that everything seemed to be a little worse at CVH, which was interesting. I was a little surprised by that, but that may be more about staffing and mandatory overtime and all that. I don't know the nuance of that, but you know, my sense of this from a management point of view is there's really a lack of teamwork and lack of feeling of respect for the staff, lack of feeling as though they're heard, they're listened to, and clearly the whole overtime staffing, that's a separate issue that needs to be dealt with. I mean, stop having mandatory overtime, staff the place adequately, so you don't have to do that. I mean, that's a kind of a separate issue, separate but not unrelated, right? If somebody keeps telling you to do mandatory overtime, you're going to feel disrespected and you're going to be pissed off and all that. But I think there's I think the bullying issue, and I think just a comment. Obviously, we can't conclude this from the survey, but Paul's right. I mean, if you're in an environment in which, you know, everybody's kind of bullying everybody, it is kind of almost natural, right, that you might do that. And again, I'm not saying we can infer that. But it certainly, you know, doesn't bode well, right? If you have a zero tolerance for bullying in your environment, you're probably a lot less likely to bully a patient.
And I think in some ways you can make that inference, because once a bully, always a bully. You're not going to just bully people you work with. And as you get more and more frustrated, as you said, John, and also the patients are the lowest hanging fruit. And for a bully, that's who they usually go after, is the lowest hanging fruit. So I think that it raises a pretty strong inference of what could very well be happening with patients. And that goes back to my question. And I wasn't thinking, because I'm not a social scientist, I'm a lawyer and I'm an advocate. So I wasn't thinking about qualitative answers versus quantitative answers. I was just thinking that if we see this bullying, it's reasonable to make an inference that it does reach down to the patients. And if you're bullying patients, that really does get to issues of safety and patient care. So it really gets there. And I don't think it's a big leap to get to make that inference.
I just wanted to say, it's from the perspective of where I have done most of my nursing, the length of stay, the fact that some of the people at Whiting and at CVH, they have buttons that can be pressed. And so when you have a long-term care and you have people that are walking and you're looking for control, bullying is one of the big tools that can be done. And then, as Nancy mentioned, when you are bullied, the only thing you probably can do is bully back. And so you look at the patients who are compromised or might have some issues and they're not quite as quick as the rest of them. So they're at the mercy of the staff. And I agree, Dr. Rodas, you usually grade teamwork, not bullying. Lori, did you want to say something?
Yeah, well, actually, I wanted to thank John for providing that perspective as well, because that's helpful coming from somebody else who has managed large, organizations in healthcare in particular. But the other point I wanted to come back to was we had talked about that focus groups and survey that was done sort of in I don't remember if it was the summer of 17 or summer of 18. And some of the same themes are like still happening today, right? So that survey of staff found that staff felt very connected to one another. They felt like, their immediate teams were supportive and they reached to each other. They felt validated by their peers, but then there was a disconnect between management. There was a feeling like we weren't heard. There was a feeling that we weren't listened to. Inadequate staffing was one of the primary things that was mentioned then. That's been a point since I started, probably before then. So I wanted to point out, and I think it might be a place for us to think about things if we look back at that focus group survey report that we got sent, as well in looking at this one. There's some of the same themes. I think the bullying is a bigger thing now than in that survey, but a lot of the other stuff is very consistent, meaning it hasn't shifted much.
Dr. Rose, do you have a thought?
The only thought I had is I changed, no, I didn't, but I changed my settings on my computer and I'm hoping you hear me better now. Is that
Yes,
any
we
better?
do.
Thank you. That was a
Are there any other questions for Sarah? So I guess we're asking, when you give us the report, will you be giving us the verbiage that was at the end of the open-ended question? Will that be there in word for word, or will you be just?
No, I think I reduced it down to 14 pages within that appendix. There was a lot there. So I tried to, I themed it and reduced it down to, 12, 14 pages for you folks to review. And I think, through analyzing it, I selected ones that were the most representative to, so that you had a nice cross section of comments.
So in comparison to what this employee population and the work that they do, you have done other studies, obviously, of workplace and staff and so forth. Do you see any similarities or some stark contrasts?
Well, most of my work is like in public health and mental health, some in corrections, chronic disease. So I wouldn't say that, I don't want anyone to misinterpret that I am a organizational psychologist or, by any means. But I would just, again, there's clearly something going on. And, I think we tried to highlight that in the report. So I think it would be, up to the task force to kind of find what they think they'd like to present to the legislature, to make recommendations to the legislature, and then see what path to take. But I do feel fairly strongly that it has to be, to use a sports analogy, like it has to be a full court press. Like you can't like just say we're just going to do one thing and magically everyone's going to be, you know, the environment, you know, the climate's going to change. Like it, you really, like there's a lot that like that needs to, there's a lot that needs to be.
This didn't get created in a day, and it's not going to get solved in a day.
Well said.
You know, and I mean, to me, it's just a kind of a microcosm of what has become of institutional care. I mean, when you look at it from the developmental side or the mental health side, large institutional care is, you know, quickly not becoming the answer. But I guess I want to put out that I would like to get like all the comments instead of just a representation of them, because I feel like that they would better help me understand what people are saying instead of like someone getting cut, you know, their words getting cut out.
Yeah, we could probably do that. I would want to go through, and we did, you know, lightly edit just in terms of, you know, like if they didn't capitalize their words or they wrote in all caps just because it made it sound like, you know, they're yelling, or so we did go through and make some small edits, and we removed things that were identifiable in terms of, you know, perhaps race, gender, location of work. So we took
Why the
those out.
locations there? I wondered why you, excuse me for interrupting you, but I wondered why you cut out the location on those where you said at X, you know, X used to be a great place to work, or I love working at X.
Well, I just wanted to make sure that everything was kept confidential, and I don't know if, I mean, I guess if we could keep in, I think I was probably being overly cautious. We could probably keep in if it was just CVH or Whiting, but maybe if it breaks down any further than that, like if it says unit, whatever, I'm not sure,
Yeah.
but unit at, you know, unit whatever, that we would remove that. What do you?
Yeah, I mean, there is a qualitative difference between CVH, Whiting, and Dutcher. So I think that those three pieces of information would be helpful. And as much as I really hate reading anything in all caps, I want to know if they're yelling.
All right.
I think where this is those open-ended questions, maybe the best picture we have of a larger segment of the staff than we have been able to access so far. And as has been brought up, the safety and the environment and the bullying all are of concern, but at the same time, we, as you so astutely said, we have to pull that all together. And by actually being able to lay hands or eyes on what has come from people who have responded to the survey might make a lot of difference for some of our understanding of that situation.
Tara, can I ask again? I can't remember it from the survey. What percentage of the workforce submitted written comments?
10% of the workforce,
Okay.
35% of the survey respondents.
Respondents.
Okay, but
I mean,
what
from-
about the use?
As the other social scientists in the room, I guess I would also just encourage everyone not to disregard the quantitative results,
Oh, yeah.
because they're important as well, and also they do, I guess they provide more of a picture, because they're, I mean, that's why I asked how many respondents that is. I mean, we're talking about 10% of the response, just like everybody that we saw, that we heard from, their feedback was important and is helping us understand things. But I think we need to like look at the entire picture as well. I don't want that to get lost in looking at just the qualitative stuff. Sarah did a lot of hard work
Right.
shaping out the quantitative pieces as well, and that's just as meaningful. So
Yeah.
But then you
that's-
also have to factor in the 73% of the people that didn't even bother to respond
Right.
correct.
into that. So
Dr. Rhodes, did you have something?
I just want to say, so I don't mind getting all the comments. I'm not sure I necessarily wanted them, but now that I hear that my colleagues, I'm fine with that. But I also still would like your encapsulated version, if you don't mind, because you've lumped them together with themes, and that would be helpful. Because if I just read through a whole string of answers, I'm gonna have to take notes to make those themes. So if you wouldn't mind that, I'd appreciate it.
Mhm. There were some comments that said, please do not share this. So those will be removed.
Well, were they talking to you or were they talking to us?
Right, I agree. Yeah.
I will not share those.
I know that you probably, the anonymity of their responses. But
It's
is
an
there,
ethical question. If the patient said, if the respondent says, please do not share, I don't think Sarah's in a position where she can share
Yeah.
with us. So I think
No
she's
way,
got
we shouldn't even be
the right
asking Sarah to
approach.
do that.
It's not a right. It's
I'm
kind
gonna
of
back up the survey here.
wow, I mean, I'm just saying, was it something, well, never mind.
To be honest with you, it wasn't anything.
Okay,
Yeah, it wasn't anything different than other
or
things.
troubling,
But regardless, if somebody said,
understand. So, any more questions for Sarah? We want to thank you very much for this. And we look forward to hearing and seeing the other items that and your final product. But I think it's, from my perspective, it has supported some of my thoughts about what's going on here.
Agreed.
But,
When will we get the final? I'm sorry, Sarah, when did you say it? I forgot it. When?
yeah, as soon as I get off of this, and my apologies for the delay.
Oh, okay. Oh, great. I didn't realize it was that quick. Thanks so much. Appreciate it.
Yeah, no, that's my fault. I'm sorry.
Last call. Well, again, thank you to you and your team, Sarah, and we look forward to the report. And we
All right.
appreciate your help today.
All righty, thank you. All right, bye-bye.
Aye. Any thoughts or comments? Dr. Otis?
As I said, I think I was a little surprised, but not really that surprised based on what we've seen and heard up until now. I was just a little surprised, I think, about the amount of I'll put it in the bullying category, but it wasn't all bullying, the uncivil behavior and disrespect and all of that. I think it's going to be very helpful to us in formulating our response to the legislature.
Paul, are you thinking of saying something? I thought it's like,
no,
okay.
I'm just agreeing with John that, it's I think it kind of puts a proportion on it. It's like we knew it was there, but how much?
It should be particularly interesting to Demas, frankly, to see in this kind of a format what their employees are thinking.
So, given the nature of what we heard today, I'm not sure we could come to any discussion or a reality of recommendations we would like to put forth right now. I know, just so everybody knows, I know that Beverly put another hour on this today. Ev, are you here?
Yes, I am, Linda.
So how long were we scheduled to go to?
I think you were scheduled until 3 or 3:30. I don't remember.
Okay, all right.
But Zoom will not cut you off, so because of the account that I have.
Okay, okay, thank you, thank you. I asked, can we leave the survey and move to the legislation that was passed, and any thoughts that people have on that? I asked her to send out the PSRB legislation that was finally passed, and, oops,
It's the legislation regarding the search of patient rooms at Whiting
yeah,
and
the
membership for
searches.
the board.
Is anybody prepared to discuss that now?
Can I just ask, I mean, I defer to others on the task force, but does that language that's in the statute seem like it gets to the problem that had been
Yeah,
identified?
that's what I really want to know.
Well, certainly in terms of the searches. Yeah.
Yeah.
I
Okay.
think, yeah, that we had discussed, or this was the language that, when we talked about this, I think Mary Kate had brought up this bill that was under review. And that was the language that was discussed.
So in our final report, we can acknowledge that, you know, we were in the process of recommending this. It seems like it's been addressed in the legislation
Right,
that's been
right.
enacted. So I think it's good to point out that we, generally speaking, concurred with this, and, you know, to acknowledge that it really did happen.
I have a hunch
As
maybe we
opposed to
were
it never-
inspirational in this, perhaps.
Could be, but it's been kicking around for a while, as I understand.
I think it was
Yes.
already underway.
Maybe someone was,
Yeah.
maybe someone was listening.
I think I think it just makes sense to, like, you know, we're already preparing a section of the report on this, and instead of saying, you know, we recommend that this happen, we just change it to we support the recent legislation that enacted this change or whatever.
And the other thing was about the advisory committee and the Whiting Advisory Board. And it actually did capture some of the thinking that we discussed here about putting people with lived experiences on the board. But I'm looking for it feverishly, but I'm not sure I'm going to come up and sometimes not here. Oh, here it is.
I think for that one, for the Whiting Advisory Board, again, we should probably say, you know, we support the recent legislation that added these two people, but I think our recommendations around that are going to be
I have it here if you want me to
bigger
read it
as
to
well.
you. If this is what it actually, I think we went into a little bit more detail, but this is Substitute Bill, Public Act 2175, an act concerning various revisions of statutes concerning the Department of Mental Health and Addiction Services. That has the part about the Section A is that when such search is conducted by police officers and probable cause exists, that contraband or hazardous items are hidden in the patient's living area, that's the only time that they would not allow the patients to be present.
Mhm.
And then on Section 2, it talks about the advisory board for Whiting. And I think we've talked a lot about this, but just let me say that what they did do was they added, along with the number of people that had already been itemized as being needed for the board, they had like a licensed physicians, 3 physicians licensed to practice in the state, 2 of whom shall be psychiatrists, 2 attorneys of the state, at least 1 of whom shall be in active practice and have at least 5 years experience in the trial of criminal cases, 1 licensed psychologist with experience in clinical psychology, 1 licensed clinical social worker, and 1 person actively engaged in business who shall have at least 10 years experience in business management. And here's the addition, and 2 persons with psychiatric disabilities, at least 1 of whom shall have received inpatient services in a psychiatric hospital. It doesn't really give the board much more starch. It's kind of very weak. And we also talked about other people. Yes, Lori, you're raising your hand.
Yeah, well, because I was thinking, I think that we're going to have a larger recommendation around this board.
Yeah.
So within that, in our report, we can acknowledge, we support the recent addition of these 2 people onto the board, but here's, a whole lot else we have to say about it.
I think, yeah, that's, but I just wanted folks to know that that is what had and went forward. So,
I
want
had
you
an
to-
additional question about the other piece of that bill.
Yes,
And I don't know if anyone can answer this, but so like in section 3B, I think it's on end of page 3 or 5, it says all department divisions and facilities shall provide their patient records to the electronic health record system established pursuant to subdivision 7 of subsection C of this section. And disclosures of patient information from that basically outside the department shall continue to be in accordance with applicable federal and state law. And then it refers to this establishment of an electronic health record system, which to me, it sounds like it's authorizing communication or sharing of information across agencies within DEMIS. Am I reading that accurately, or?
Yes,
Yeah,
it is,
so
Lori.
one of the things, Lori, that Demas was trying to do was get it so that they only need to buy 1 suite of software
Yeah.
for electronic medical records, and so they wanted all the different like Capital Region and SMA and Swiftness and all them to just be able to get the same software as a group, as opposed to having each agency buy their own software. And so I have concerns about it because, they're putting records in, and it could be that, I start at Capital Region, then I go to CMHC, and I have this record that just follows me everywhere without a release.
Okay, so I am understanding that correctly. Okay.
Yeah.
I do not have
hand. Does
I-
Dr.
I-
Rhodes have his hand up? I don't know where this little hand came from in my area. Is this something we want to discuss at another time of this passage of the bill? Or I have a hunch, Paul, because I just got a thing from the federal VA about electronic health records. I wonder if this isn't something that's from the, no. Okay.
No, this is something that Demas actually tried to get in the last legislative session.
Okay.
As
So-
well,
so this
and they didn't,
is-
and so it sounds like they piled it into this.
This is what is making it what's called a covered entity, like one single covered entity as far as sharing of PHI. Is that my understanding?
Yes, Lori, that's similar, that's close to what they're trying to do, where all DEMAS patients, instead of, for example, if you're in Middletown and then you end up in Hartford, Middletown currently will have to fax that information over.
Right.
They're going to be able to give all of the access to the medical record for individual patients. It's like a hospital system. They're making them into an entity.
Right.
The
All right,
federal-
that's
the
fantastic.
federal, bill you're referring to, Linda, was about patients have to be granted, as of now, immediate access to their medical record, including the consultation notes, the progress notes, lab results, imaging results, with just a few carved out areas, whereas, which I think is in general a good thing.
Okay. I just want you to know that Lori and I are working on the report. But a lot of what we did today and what we'll hear from this report will, the survey will have be factored in. But Nancy, you had raised the issue of bringing about that case. Are you still wanting to put that to the agenda?
I think we need to talk about it. I think it's really important. Yeah.
So I'm not sure we should dive into it today, but unless you want to talk about it now.
Well, I wasn't prepared to since
Okay,
I was,
so we'll put it on the agenda for the next
Well,
meeting.
and Linda too, I think if we're getting the final report along with the extra data, it might be good to like review them both in like 2 weeks or whatever, so that we can have this shape it.
Yeah. I was going to bring up the fact that we need to be meeting every 2 weeks, especially in the summer.
Yeah. Do we want to finish?
Yeah.
Well, I'm not going to be available. My daughter's having some surgery, so in 2 weeks, I'm not going to be available, and that's why.
Oh.
Well,
That's why I was asked.
missing one day, but I mean, I don't want to like start again in October here, you know?
No. I mean, we would meet in July. And then if we saw we needed to do 2 weeks, then we could
Oh,
do
like
that.
next
but
week?
No,
can't do
next week.
I'm on vacation
July
next-
1st is a Friday, I believe, isn't it? So you're saying not
Next
that
week?
week?
The second.
Second, so like the 9th.
You're saying skip that week and go to the 9th?
Are
Linda,
people
is that what you're
prepared to
saying?
wait?
Now we're going a month again.
Well, that's 3 weeks. That's 3
No,
weeks.
Yeah, 9th's 3 weeks from
Linda
now.
said she couldn't do 2 weeks from today. So what about 3 weeks from today? July
That
9th.
works.
July what?
July
Ninth.
9th.
Okay,
Beverly, you got that?
Yes, Dr. Rudy.
okay, July
order-
9th.
In order to, I guess, help facilitate that discussion, can we all try to read that report along with the data and come up with, a couple bullet points of things that we might want to see, and then we can kind of talk about those as a group.
Right,
You're talking about the survey report or
Right.
is that what you're talking
Yeah,
about?
like,
Oh, okay.
force ourselves to decide what would we want to recommend based on those results, and then we can bring those to the table to discuss.
Right. And this other thing you guys were alluding to that Nancy wanted to bring forth, I mean, is that?
That
I don't-
is
I don't know the
the- that
detail,
will-
but.
Say
Well, I
again.
guess what I sent out, I sent this out a couple of weeks ago. A
Yeah.
lawsuit filed against Demas.
Yeah,
for-
I saw that. I saw
Right.
that, but is that, do we need to, I guess my question is, do we need to discuss that as a group?
I think so, because it relates to safety at the institution. And there's, the unit was closed because of safety concerns, and there's a question about how long were they letting this unit operate when they felt that there were safety concerns. I'm sure the emergency which was the rationale for shutting the unit and moving patients and staff around didn't just happen overnight. So, I have some concern, and I think the task force should have some concern about the fact that there was a unit that was being operated under these kinds of circumstances.
Yeah, maybe I wasn't clear. I'm sorry, Nancy.
Okay, Nancy, may I say something?
Yes.
Yes, please, Bev.
On June 8th, the federal court took up the case. And they ruled that it was okay for Demas to transfer the patient.
No,
Yeah,
what
they didn't give,
they ruled was they denied the
The
plaintiff
restraining order,
for a temporary restraining order.
yes.
But the main part of the case, which is about the state's failure to comply with the terms of the Roe v. Hagen consent decree, is still ongoing. So the case is still ongoing.
My next question is, do you want to be discussing an open court case on a task force before there's resolution? I'm not an attorney, I'm just asking.
Yeah,
Well, it's a public record.
yeah.
The documents are in the public, the
I
hearing.
want you to know that every one of my screens are frozen.
That's probably your Wi-Fi.
Yeah.
I think it makes more sense to talk about what we think are the broad strokes issues that need to be addressed by us. And I don't know that it's necessarily, it's necessary to speak about that particular court case, rather than just talking about what we think are the concerns that need to be addressed or what recommendations we have to the legislature.
I think
And I think
I
this
see
court
Nancy's
case
point about the
brings out-
closing.
Yeah, this
Yes.
court case brings out some broad strokes issues that we have to look at, which is whether the institution is being operated, is operating under some dangerous circumstances, and that we have some concern for patient safety. So we don't have to talk about the particulars.
Nancy, is this case like viable, or was it put on the shelf, or what happened there?
Well, courts don't do it either. I mean, that's not a term you use in court. It's an ongoing case.
It's pending litigation.
It's pending litigation. And the issue right now is whether the state, whether Demas violated the Roe v. Hogan consent decree. We don't care about that. That's not something that is something that we have to think about. But the state was admitted in their documents and at the hearing that this unit was dangerously understaffed and it was an emergency and they had to close it. So as a task force, I think we have to be concerned that the state that Demas was letting patients at Whiting live on a unit that was, and that they knew was short-staffed and was operating under dangerous circumstances that were so dangerous that they were forced to close it.
Yeah, I mean, I think this falls right in our wheelhouse. I mean, honestly, this is what we're supposed to be looking at.
Yeah, I wasn't implying,
Right.
Again, I think I was maybe misconstrued here. I wasn't implying any of that. I actually think it's all very relevant. And listen, I've been a champion about patient safety for a long time. I'm glad they closed the damn unit if they couldn't staff it, by the way. That's the right thing to do from a management point of view. Well, the question is, do we need to discuss it? We just discussed it. Is there more to discuss than in the report?
Well, I think it does strengthen our position that we took about the staffing, as does the whole case strengthen, some of the things that were enumerated in that case strengthens our findings that we, and some of the conclusions that we have come to. I see that as one of the things. But I'm going to, Mike, do you have any thoughts on this?
Yeah, so I think, obviously what was distributed is a motion. Basically, my interpretation is they're trying to reverse the decision to consolidate some patients into other units, right?
Not really.
No.
What I mean, that's part of it, but you have to look at it from the context of this is a 30-year-old consent decree.
Right.
This is not new litigation. This is, and that's the reason it's captioned as a motion. It's a 30-year-old consent decree that the plaintiffs are alleging the defendants violated.
Right.
And they violated it by not providing adequate notice to the patients of the closure of the unit. Now,
right. The catalyst is the closure of the unit, right? That's what they're going into court about.
But but the substance of what it's about is the closure of the unit. And the concerns that I think we have to address are the fact that a unit was being operated under conditions that were so dangerous that Demas felt they had to close it. We don't have to look into the whole business about the consent decree. That's not what the task force is about, but we're concerned about patient safety. And we're concerned obviously about staffing, to the point that we spent all this money to to do a survey. And if a unit was so short-staffed that the people who run the unit stood up in court and said that it was an emergency, it was so dangerous that we had to close it, then that's something we have to be concerned about, because it didn't become an emergency the day they closed it. It was building up over time. And that's something that is directly within our bailiwick of what we have to think about.
Nancy, wasn't there also an issue of patients who have not gotten along being put back
Yes.
together again?
Yes.
Yes, that they were placed back on units where they had problems and people
Yes.
had really been violent against them.
Yes.
Yeah.
Let me just say that the way in which we are going about writing this report, we're putting in findings, all right? Like this would be a finding.
Yeah.
Why did we decide that we had to say stuff about, say things about the staffing? This is a finding, and that this is influencing our recommendations about the staffing. And probably a lot of stuff that we heard today will be in that particular section as well.
I mean, it's part of the evidence that we need to take in to make the decisions that we have to make that go into the report. We can't ignore the fact that the staff at Whiting chose to close a unit because it wasn't safe enough to keep operating. I mean, that's exactly what we're supposed to be looking at.
So
And that's
all
not
I-
a controversial fact.
All I said is I believe the catalyst for this motion was the decision to close the unit, right? And in the
Close
context
the unit and to not give the patients the rights that they were entitled to.
right, I got it. No, I got it. But I mean, it's all derives from the decision to close the unit. And so, and I have to say, I read the thing, there's nothing in there that really surprises me, because that's been my general sense of the problems at the hospital
Right.
for many years, right? I mean, it's understaffed. There's way too many people in there in terms of patient, I mean, that's my general sense. So, but you're right. I mean, this is exactly what we've been talking about this whole time. And, I guess they got to the point where they just definitely don't have enough staff to staff what they've got. And so they made this decision. But the underlying problem is persistent.
Okay, Dr. Otis, are you?
No, I guess that was my point. I think there was not, I get it, and I'm fine if we need a whole meeting about it. I just think it substantiates everything we kind of knew, I thought already. So but
Maybe
that's fine.
maybe this is
We'll
enough
talk about it
discussion.
Yeah.
I'm fine as long as as long as we've had an opportunity to discuss this, and we all seem to acknowledge that this is part of the ongoing problem and that it's evidence that we need to use in writing our report and in making our determinations. It's just not.
Our recommendations. Do you want to synthesize that, into a paragraph or two or something, Nancy?
Sure.
Okay, you're on.
Okay.
Cool.
What are the agenda items for the next meeting, please?
Say again, Bev?
What are the agenda items for the next meeting?
Is that going to be that we're going to hopefully have, did you hear we're hoping to be meeting on the 9th of July?
I have that right, yeah.
And I thought that perhaps Sarah might have, a little more, or maybe have the finished product of the.
We're gonna have that tomorrow. She said.
Yeah,
Oh,
she said
yeah,
she's
that's
gonna
right.
send it right after.
So
she
we'll
got it.
discuss it, and from that perhaps,
She sent it
it
to-
will.
She sent it to me and I will forward it to you guys once the meeting is over.
Okay, good. So then we can discuss that, and from that hopefully evolve more of our recommendations about the staff and conditions. So those would be the two things on the agenda. And
Yeah, that sounds good.
all right. Is there any more business to come before us? Hearing none, I will entertain a motion to adjourn.
So moved.
Seconded.
And no one has objected, so the motion passes. Have a great weekend, everybody.